Welcome to postgraduate class in obstetrics and gynecology, and today's topic is test for ovarian reserve. In the adult ovary, what we can see as most of you must be aware, but it is just a short revision is at the cortex there are many follicles in the various stages of development as well as corpus luteum or corpus albicans can be seen, whereas at the medulla there is mostly the fibrous tissue which is present in the ovary. So in the cortex, we have primordial follicles. What do you mean by primordial follicle is there is a oocyte in arrested stage of meiosis and it is surrounded by 13 pregranulosa cells. The cells which are surrounding this primordial follicle, these are called as pregranulosa cells. This primordial follicle next progresses whenever there is a follicular development. It goes on getting converted into primary follicle. Primary follicle is oocyte which is surrounded by 105 granulosa cells is the latest study which has shown that the number of cells which are surrounding this oocyte in the primary follicle, it is slightly larger than the primordial follicle and number of surrounding cells also are more. Further follicular development takes place and then the primary follicle gets converted into preantral follicle. Preantral is the size is bigger than primary follicle, but still there is no cavity or antrum in that. There is further proliferation of these granulosa cells and there are Paul Exner bodies which are seen in that. So these are the filled bodies are there, and when these bodies they come together, then there is a formation of antrum or cavity which is filled with the follicular fluid, and then we call it as a antral follicle or Graafian follicle. Further development takes place in the Graafian follicle, then we call it as a pre-ovulatory follicle. What we can see in the ovarian cortex, there are also atretic follicles which are going for atresia, because whenever there is a recruitment of the follicles, one follicle will proceed to develop into Graafian and rest of the antral follicles will go for atresia or apoptosis, and these follicles are called as atretic follicles. But whenever we do antral follicular count as a test for ovarian reserve, then we are counting both these antral follicles as well as the same size follicles which might be going for atresia. It is very difficult by ultrasonography to differentiate between these two. And we have our early corpus luteum, mature corpus luteum, and corpus albicans is also present. So if what is the functional unit of adult ovary? It is the primordial follicle, and then as follicular development takes place, it goes on developing into a mature pre-ovulatory follicle, and then ovulation takes place, and then it gets converted into corpus luteum. Now this follicular atresia is going on throughout the life, and it is because of the regulated apoptosis. Apoptosis is programmed cell death, and this programmed cell death leads to this process of follicular atresia, which is going on throughout the life of a woman. So in utero only at 20 weeks, it is said that the follicle number is the peak. 6 to 7 million follicles are present at 20 weeks of intrauterine life, but atresia is going on in the fetal life also, so that at birth only 1 to 2 million are there. Further, atresia is going on throughout the prepubertal life also, so that at puberty the number is reduced to 3 to 4 lakhs. And then every cycle, one follicle will go for ovulation, whereas rest will go for atresia. So by age 40, 25,000 is the expected count of the residual follicles which are remaining. And by menopause, around only 1,000 follicles are there. Now, what is interesting to understand is the rate of depletion increases with age. That means the process of this regulated apoptosis, it becomes further and further more and more intense as the age advances. Second important point is not only the number of follicles is reducing, what else is happening is even the abnormal oocytes are also developing more frequently, so that there is aneuploidy increases with age, especially trisomy, monosomy. All these aneuploidies are more commonly seen with advancing age when there is a reduction in the number of follicles. It is not only reduction in quantity, it is associated with reduction in quality also. So this is all how the reproductive aging takes place. This is the title which is given in the textbook for this is this phenomenon is reproductive aging, and the part of reproductive aging is ovarian aging. And in the ovarian aging itself, there is a reduction in number of follicles as well as there is a reduction in the quality of the follicles with increase in the aneuploidy. Now, what is the definition of ovarian reserve? What do we understand when we say how much is the ovarian reserve? Ovarian reserve, uh, it is related to the size as well as quality of remaining ovarian follicular pool. Both these. How much is the size of remaining ovarian follicular pool, or how many follicles are there, and how is the quality of the remaining ovarian follicles. So size and quality both. And second, clinically, which is relevant about the ovarian reserve is whenever we say patient has good ovarian reserve, what does it indicate? It has the patient has or ovaries ability of the ovaries to respond to exogenous gonadotrophin stimulation is good. If I say the ovarian reserve is poor, that means ability of the ovaries of that patient to respond to exogenous gonadotrophin stimulation is poor. So we are talking about this ability of ovaries to respond to exogenous gonadotrophin stimulation where we are commenting about ovarian reserve. So it's anatomically it is how many follicles are remaining and how are the follicles quality wise. But clinically what is more important or what is more uh, useful to understand is when we say ovarian reserve, we are talking about what is the ability of the ovaries to respond to whatever ovarian stimulation we are doing with the exogenous gonadotrophin stimulation, especially in patients who require induction of ovulations or over stimulation in an IVF cycle. Now, these tests for the ovarian reserve are more commonly being used since last 2 decades, 2 to 3 decades only. And what is the objective of testing for ovarian reserve? We want to, this is a screening test. All these are the screening tests. We are doing screening of the population or patients who are patients of infertility, for example, to know how much is the ovarian reserve. And this screening test we are going to identify a disease, and which disease we are going to identify is diminished ovarian reserve. So diminished ovarian reserve is a disease for which we are conducting the screening test for ovarian reserve. Diminished ovarian reserve indicates it is as equivalent to saying reproductive aging of ovaries. Whenever there is a diminished reserve, that means the ovary, there is a reproductive aging of ovaries has taken place. And it also indicates that there will be increased possibility of aneuploidy whenever the test will indicate that patient has diminished ovarian reserve. Now, how we should interpret this test? Suppose I um, advise a test to know the ovarian reserve and I get a report. So, how I should be interpreting is what I should understand is sensitivity of any test is ability to detect true negatives. Specificity is ability to detect true positives. Positive predictive value on the other hand is if the test result is positive, how much is the probability of the true positive for that patient? And it will be more in a high risk group. It will be positive predictive value will be low in a low risk group. Negative predictive value also same. It will be better in high risk population. It will be low in a low risk population. So positive predictive value, negative predictive value are dependent on prevalence of disease in a given population. For example, if I am doing the testing for ovarian reason in a elderly population, elderly woman, then the positive predictive value and negative predictive value both will be more as compared to if I do the test in younger women. Unfortunately, there is no gold standard test for this diminished ovarian reserve. As opposed to when we do for the cervical cancer, we do the screening test to know the pre-invasive cancer of the cervix. And we suppose say we are doing HPV testing. or we are doing cervical cytology. We do have cervical biopsy as a gold standard to compare. But as opposed to that, here for the diminished ovarian reserve, there is no gold standard test. No, most of the tests, whatever tests are available, they have high specificity and low sensitivity. That in a simpler language, it means that if the test shows abnormal result, possibility of having a poor response to gonadotropin stimulation is uh, poor response to gonadotropin stimulation is more. But if the test is normal result, that doesn't mean that always patient will have a good response to gonadotropin stimulation. I hope you understand this difference between specificity and sensitivity. Now, if a patient, suppose she has a normal ovarian reserve and the test is false positive, that means you have a report which tells that she has a diminished ovarian reserve. There is so much of psychological damage associated with that, and she might be exposed to unnecessary aggressive treatment. So that is why false positives are more dangerous as far as ovarian reserve goes as compared to false negatives. Now, what is the clinical utility of these tests? These tests, they are useful to prognosticate or to tell us the prognosis of successful ovarian stimulation during in vitro fertilization, as well as they give us the prognosis for getting adequate oocyte number for oocyte retrieval in an IVF cycle. Suppose you do the test and the test result is showing that reserve is good, possibility of having a successful ovarian stimulation and oocyte retrieval is more. It is more useful in high-risk group of women for diminished ovarian reserve. As I said, positive predictive value will be better if it is done in a high-risk group. It helps for pre-treatment counseling of in vitro fertilization. That is an important thing. Whenever we are counseling, the most usual question the couple might be asking is how much is the success rate? How much is the possibility that I will be getting a successful pregnancy? And for that, these tests will add useful information whenever we are doing counseling. Generally, retrieving between 5 to 14 oocytes is considered adequate for a patient who is less than age is less than 35, and for elderly more than 35 years, we need more number of oocytes are to be retrieved from 10 to 34. Now, what these tests are not helping us is to predict how much will be the possibility of pregnancy in the given patient. That is not told. What we know is how much is the success rate of the ovarian stimulation and how much is the success that adequate number of oocytes will be retrieved. But how much is the possibility of having a successful pregnancy is not known. Miscarriage rate is also not known. For all these, age is a better predictor rather than this test. Successful pregnancy rate is not known. Age of menopause, that should also not be um, derived or predicted on the basis of this test. Timing of open cryopreservation. Now, more and more women are going for career and then having late marriages or late decisions for the childbearing, and there is always there is a possibility that they might be going for cryopreservation. But when to go for that should not be decided on the basis of these tests. Fertility potential of a woman before attempting pregnancy. That means she has not attempted only, and we do not know whether she has infertility or good fecundity. And in these cases, fertility potential should not be guessed on the basis of these tests. Now, this slide shows the steps of IVF just as a revision, so that what we gain by doing this test is how much is the success for controlled ovarian hyperstimulation, which is a step one. How much will be the adequate yield of the oocytes, that is ovum retrieval, how much will be the success, that we know by this test. What we do not know are the next three, that is fertilization and embryo culture, then how will be the quality of embryo, and how much successful will be the embryo transfer. These three steps we cannot prognosticate about these on the basis of this um, test for diminished ovarian or for test for ovarian reserve. What is most important is no patient of diminished ovarian reserve should be denied assisted reproductive technology. That is the most important golden rule, I should say, about related to this test. Indications for test of ovarian reserve, or we can say what are the high risk factors for diminished ovarian reserve. Infertility with age more than 35 years is a specific indication or agreed indication, but whenever it is patients, women's age is less than 35 years, then specific cases only we should be advising this test, such as there is unexplained infertility to rule out unsuspected or surprise diminished ovarian reserve. Infertility when there is a family with family history of early menopause, because the age of menopause usually runs in families. Infertility with previous ovarian surgery, such as ovarian cystectomy, drilling, or unilateral oophorectomy, chemotherapy or radiation. Infertility patient who is a smoker, and infertility patient with demonstrated poor response to exogenous gonadotropin stimulation. So these are the specific indications, and I think postgraduate students should be aware about that, because you might get a SAQ on this test for ovarian reserve, or you can get a LAQ on investigations in a patient of female infertility, where you will have to write about that. Or in practical examination, you can get a case of infertility where you might be asked about this question, that what are the indications in which patients you will like to do the test for diminished ovarian reserve. Now, these tests help for counseling an infertile couple to plan the treatment strategy. For example, whether to try initially intrauterine insemination or to directly go for IVF. Then to use available resources such as pre-implantation genetic testing when there is a possibility of reduced quality of oocytes in patients with diminished ovarian reserve. What these tests are not, when these tests are not indicated, to assess fertility potential in general women population. We can't use this test in general population, because as we have seen previously, in a low risk population, positive predictive value and negative predictive value both are low, and that is why this should not be used in a general women population to assess the fertility potential. Then these tests do not predict age of menopause. They do not help us to take a decision for ovum cryopreservation. They do not help us to predict pregnancy rate in IVF cycle. That also we cannot guarantee the patient, or we can't say that the possibility of successful pregnancy is less or more dependent on the result. And what is most important, as I said, is these tests are not indicated to deny ART for any infertility patient, because it has been seen that even in spite of having a very poor result of diminished ovarian reserve, there are reports of successful pregnancy in the literature. And the basis for especially for these is positive predictive value of test is low in low risk group, and that is why it should not be applied to the general women population. Now there are total 6 tests which we can divide into two parts, two groups. First is the screening test for ovarian reserve, which are of clinical utility is more. And second group is where the clinical utility is less or less commonly used in clinical practice. Anti-Mullerian hormone is number one, which is used. Antral follicular count is used, and basal FSH with estradiol. What is less commonly used is inhibin B estimation, ovarian volume as a predictor of diminished ovarian reserve, and clomiphene citrate challenge test. These three tests have almost been replaced by these three because of the poor sensitivity and less reliable. The intercycle and intracycle variability also is great with all these tests, and that is why ovarian volume will reduce as a last stage. Before that, it is a late marker, and that is why it won't help us to know the patients where there is a mild decrease ovarian, diminished ovarian reserve, and that is the reason these tests are no more. Clomiphene cited challenge test. It is where we have to do the FSH testing twice before start giving clomiphene and after giving. But it doesn't add to whatever we gain the information by these tests, and that is why these tests have been almost completely replaced by these three tests in the clinical practice. Anti-Mullerian hormone, it is a transforming growth factor beta subfamily protein, that is TGF beta protein. Same are the this what we say being produced is the inhibin and activin. These are also belonging to the same transforming growth factor beta subfamily. With these two, even anti-Mullerian hormone also one of that. It can be tested at any time of menstrual cycle is the main advantage as compared to other tests. It is produced by granular cells of pre-antral and small antral follicles of 2 to 6 millimeter size. So once the size increases more than 6 millimeter, the production of antimullerian hormone is less. This number of small antral follicles, it correlates with the remaining follicular pool in the ovary. And that is the reason why AMH is number one if you say or if you see all the tests for ovarian reserve. Its major function in fetal life in regulation of Mullerian duct when it is produced by Sertoli cells of the testis that we have already seen in primary amenorrhea lecture, that it has a when it is secreted by testis, it leads to regression of Mullerian duct in a male fetus. It has an autocrine that is on the cell itself and paracrine that is on adjacent cells. Autocrine and paracrine function in follicular development in reproductive age in the adult female. What it does is it mainly prevents primordial follicle development, further development of primordial follicles. So once there is a recruitment and there is a pool of pre-antral and antral follicles, it prevents the same development in the surrounding follicles or adjacent follicles. That is its main action. It inhibits the further development of primordial follicles. Its blood level is not dependent on phase of the menstrual cycle, or it is not dependent on the hypothalamic or pituitary factors. Its values are lower in patients taking oral contraceptive pills or patients who are on GnRH agonists. So exogenous administration of these hormones, then there is a low value. But in the body, if for some reason pituitary gonadotropin hormone production is less or GnRH pulsatility is abnormal, that is not going to affect the anti-Mullerian hormone level. Values less than 0.7 nanogram per ml are suggestive of diminished ovarian reserve, or some studies give it as less than 1 nanogram per ml. More than 5 nanogram per ml we have already seen in patients with PCOS, where if it is more than that, then there is an increased risk of ovarian hyperstimulation syndrome whenever the ovarian stimulation, gonadotropin stimulation is tried in patients with IVF cases. It has a place in IVF population to predict poor response to ovarian stimulation with low values. It has a definite place, but it fails to predict about the pregnancy rate in a given patient. It is a commonly used test for ovarian reserve. Second is antral follicular count. Antral follicular count is done by doing a transmission sonography on day 2, 3, or 4 of the menstrual cycle. Follicles of 2 to 9 millimeter, and some of the studies are even including 10 millimeter. They are counted in both ovaries. Normal antral follicular count by age is less than 35 years. From 13 to 25 follicles should be seen. By up to 35 to 40, where most of the elderly women with infertility might be there. A normal count is 10 to 15 follicles when it is counted in both the ovaries. And then it keeps on reducing to 3 to 10, and more than 46 years it will be 0 to 3 follicles. So I think we should be remembering that 10 to 15 should be in elderly patients, whereas less than 35 years it can be from 13 to 25. Antral follicular count correlates well with oocyte yield in an IVF cycle. It is same as anti-Mullerian hormone, that it is giving useful information related to how much will be the number of retrieved oocytes. In IVF population, if antral follicular count is less than 3 to 4, it has a high specificity for poor response to ovarian stimulation and failure to conceive. But it has low sensitivity, so that even if antral follicular count is more than 3 to 4, it does not indicate good response to ovarian stimulation necessarily. So it has a low sensitivity, and this limits the antral follicular count's clinical utility. Third test is basal FSH and estradiol concentration. It is done on day 2, 3 or 4 of menstrual cycle. FSH level more than 10 or in the range of 10 to 20 international units per liter indicates high level. It indicates indirectly that there is a low level of inhibin B and estradiol, and there is a reduced negative feedback which is resulting into raised FSH. Unfortunately, FSH has wide intra and intercycle variations, so it is less reliable. Estradiol alone has no value, but when we do estradiol along with FSH, if normal FSH is there but estradiol is raised to more than 60 to 80 picogram per ml, it indicates a possibility of diminished ovarian reserve. If both are raised, then further worsening of diminished ovarian reserve is indicated. This test has a low sensitivity and specificity with a single test. Sometimes you need to repeat it to confirm, because there is a, as I said, cycle to cycle and intracycle variability is too high. And that is the reason it is being replaced at present by anti-Mullerian hormone and antral follicular count. Should we combine the test? Unfortunately, that doesn't improve the sensitivity, specificity, positive predictive value or negative predictive value. On the other hand, conflicting results might confuse the treatment decisions. So this combining the various tests in single patient is not recommended at present. Take home message for all of us is no test of ovarian reserve is ideal at present. Interpretation of result needs caution. No woman should be denied treatment on the basis of the test result. Thank you so much.